Dr. Akshay Sharma is an MBBS and MSc and a pediatric hematologist, oncologist, and transplant physician at St. Jude's Children's Research Hospital in Memphis, Tennessee. His postdoctoral work focused on understanding the genetic regulation of fetal hemoglobin, and as a physician scientist, he continues to advance that work in the form of novel gene therapy clinical trials for patients with sickle cell disease. He leads several clinical studies of genetically modified autologous and allogeneic hematopoietic cell transplant for non-malignant hematological disorders. In addition, he is the co-chair of the CIB-MTR Pediatric Cancer Working Committee and has led several projects assessing impact of factors affecting health outcomes after HCT for various blood disorders, especially in children. The goal of his clinical research is to advance cellular therapeutics for children with hematological disorders. He is passionate about improving access to these novel therapies in an equitable and patient-centered manner. So, Dr. Sharma, you can go ahead sharing your slides and your presentation.
Sounds good. Thank you, Dr. Gupta, for that kind introduction. And I really appreciate this opportunity to present some of our work at this forum today. I was listening to the previous talk, and I have to admit that this will be a very clinically focused talk because I'm a clinician, and so might be very different from what you have been discussing all morning. So just to give you a big overview, I am a pediatric hematologist oncologist who takes care of children with blood disorders and cancer. And I do transplantation, bone marrow transplantation for these patients at St. Jude in Memphis, Tennessee. And so our interest in using machine learning was basically to develop methods in which we can predict who is going to have an adverse outcome after receiving a transplant so that we can do something about it. So this will be the outline of my talk today. I will briefly talk about risk prediction in medicine in general, and then some of the risk prediction algorithms that we have in bone marrow transplantation. Then I will talk a little bit about the methodology that we use for developing this machine learning model for the study that I'll be discussing. I'll talk a little bit about our model assessments and some future directions of where we want to go from this eventually. So I'll start this by saying that risk prediction is essentially at the heart of medicine. From basic triage, when a nurse looks at a patient and tries to figure out if this is a sick patient that needs to be seen immediately by the doctor, or somebody who can wait, or if it's a seasoned clinician who is continuously evaluating, should I use treatment A versus treatment B? Risk prediction is at the heart of medicine. We are always trying to balance the risk and the benefit. Is this medicine going to be more beneficial than the harm that it is going to cause, or other way around? And risk prediction, we normally do it sort of in our minds without even thinking about it. So take, for example, this picture is from one of my mentors, Dr. Pui, who has been in practice of medicine, pediatric hematology oncology for over 40 years. He has treated tens and thousands of patients. He has seen various disease presentations, so he can very accurately determine the risk of a given patient based on his past experience. He can foresee complications. He can develop the best plan for those patients. And so in machine learning AI language, you would say that he has a deep learning neural network. I'm using these terms sort of loosely over here, but you get the point. In contrast to that, I have been in practice for about 5-10 years now. I've treated a few hundred patients. I can recognize patterns of complications and sometimes can foresee them, but I need some support. I often have to ask my senior colleagues for help. And so I need some artificial intelligence to enhance my activity. And so focusing on bone marrow transplantation, which is my area of practice, bone marrow transplantation is a high risk, high reward procedure. We use bone marrow transplantation to treat several blood disorders and cancer. Of course, if it works, the patients are cured of their cancer. But if it doesn't work, patients can often die because of the complications of transplant. And so accurate risk prediction is needed for appropriate candidate selection, who should undergo transplantation versus not, for prognostic counseling, so that we can tell our patients what's going to happen to them, for shared decision making, so that I and my patients can together decide what's best for them, for making informed treatment decisions, for advanced care planning, for goal concordant care, so that everybody knows what we are hoping to achieve. And finally, to improve outcomes, we need risk prediction. And so if I have a crystal ball such that I can predict who's going to get sick tomorrow, I can do something about that today. As you can imagine, early interventions are critical to improving outcomes in patients. The sooner we can identify who's going to get sick and do something about it, the sooner we can treat that patient, the sooner we can address that complication. And so risk prediction really helps us to achieve that goal. And there have been numerous studies that have shown that early interventions can decrease the organ dysfunction and often reverse organ failure that happens after transplantation. And so there are a number of risk prediction methods that are used in hematopoietic cell transplantation already. The first one I'll want to talk about is called HCTCI. It stands for Hematopoietic Cell Transplant Comorbidity Index. And so what it does is it basically looks at 17 organ function criteria, looks at your heart, lungs, kidney, etc. And based on that, it gives you a score. And the score usually is 1, 2, 3, 4, or 5. If you are 3 and above, you have a high risk of dying during your transplant process. If you're 1 or 2, then your risk is low. But it's not a very good method because, as you can imagine, there are 5 grades, but 3 and above is bad, 2 and below is better. So it really doesn't give you a lot of leeway over there. So some people try to improve this. They created what is called the augmented HCTCI. They added some laboratory values like ferritin, albumin, platelet count, and it marginally improved the prediction ability. There is also something called the disease risk index. And so this is another prediction algorithm which uses the disease diagnosis and what stage you are at. So if you are at a high risk diagnosis and a higher stage, you have a worse outcome. If you're a low risk diagnosis and lower stage, you have a better outcome. The difference between HCTCI and DRI is HCTCI looks at the patient and not the disease, and DRI looks at the disease and not the patient. And so they are both lacking in their predictive ability. And so the European Society of Bone Marrow Transplantation, they created a risk score by combining these two. They took some variables from DRI, they took some variables from HCTCI, which are mentioned over here, and they created a score. But unfortunately, the number of variables that they included in their score was so limited that once again, it loses a lot of information that a patient undergoing transplantation has. And so these risk prediction models, as I said, they are not perfect. First of all, they are not designed for pediatric patients. They're designed for adult patients. None of them incorporate what happens to the patient during transplant. So during transplant, patients get a lot of chemotherapy. None of these prediction algorithms take care of that or assess them. And most importantly, none of these algorithms assess what happens to a patient after transplant. Transplant is a very dynamic procedure. A lot of things change during the process of transplant itself. And so all these risk prediction algorithms, they look at what happened to the patient right up to the point of them receiving transplant and ignore everything that happens after transplant. So you can imagine that they are not perfect in that sense. They are based on rigid statistical assumptions and fixed data. And so because of all these reasons, their predictive ability is extremely limited. And so why did we develop this model? Our goal was to use longitudinal data, which is collected both before as well as after transplant, capture it directly from the electronic medical record, and use a machine learning algorithm to improve short and long-term mortality risk prediction for transplant patients compared to the use of baseline variables alone. So the rationale for doing this was we wanted to incorporate the changes that happen to a patient's condition after they undergo transplantation. And we had to use a machine learning methodology because the number of variables that we encountered was so large that a regular statistical model would not have worked for this application. And so I'll show you some of our methods now. Our primary objective was to predict survival at 100 days after transplant, and then secondary objectives were to predict a little bit delayed outcomes at 1 year and 2 years after transplant. We chose survival as our outcome measure for this particular study because survival is binary. You're either dead or alive. So it was very obvious for us to figure out what was happening to these patients. And we looked at data over the last several years. And so we wanted very accurate outcome measures that we could assess for. We used longitudinal data. So anything that was captured in the electronic medical record, if they had a lab drawn from 30 days before to 30 days after a transplant, we captured all of that. And let me tell you, like transplant patients, they're admitted for about 5-6 weeks um, around transplant. And so we get labs on them every single day, sometimes multiple times a day, many, many labs. So the patient may have had 10, 20, 50 labs collected every single day. So we captured all that data. We trained and validated the model using the St. Jude dataset at our institution, and then we got data similar patients from another institution in New York, MSKCC, and we did an external validation on the MSKCC dataset. And so what we did was we looked at data from day -30 to day +30. And then on day +30, we made a prediction what is going to happen to this patient at 100 days, 1 year, and 2 year, and then verified whether that prediction was actually correct or not. And so this was our study population. We looked at all patients who had received a transplant from the year 2000 to 2020 at St. Jude. They could have had a diagnosis of a blood disorder, and they were all 21 years of age or less. And they should have at least lived for 30 days after transplantation because our window of observation was day -30 to day +30. So they had to be alive on day +30 for us to make a prediction. And so we excluded some patients who were receiving second or further transplant, who were older, who did not get a bone marrow or a PBSC stem cell source. Some patients got transplanted for a solid tumor indication. We excluded those. And if we had missing HLA information, which was just one patient, we excluded those. And there were 12 patients who died less than day 30 that were excluded. So after making these exclusions, we were left with about 738 patients that we finally included in the St. Jude cohort. And then we collected variables on these patients. We collected baseline variables, which I showed you had been previously used for other prediction algorithms, and also the longitudinal variables from the electronic medical record. So the tables on the next few pages show us the distribution of the St. Jude cohort and the external validation cohort. So you can see over here, this is the entire St. Jude cohort in the second column. In the third and fourth column, we divided the St. Jude cohort into training cohort 70% and a validation cohort 30%. And then we had the MSKCC external validation cohort. The main difference over here was MSKCC data only started at 2010. And so we had data over the last 10 years from MSKCC, but for St. Jude, we had data from the last 20 years. But as you can see, the number of patients the number and kind of patients were fairly similar. Nearly equal number of males and females, as you can see over here. Recipient race was very similar. And then their ethnicity was also very similar, as you can see. The differences I've highlighted in red. Again, the donor characteristics, who did they receive the transplant from, again, was fairly similar between the St. Jude and the MSKCC cohorts. The main difference over here was at St. Jude, we do a lot of mismatch transplants. So transplants where there is a mismatch between the HLA typing of the donor and the recipient. So you can see that we had about 39% in our training cohort, 31% in the validation cohort. But in the MSKCC cohort, there were only 12% of those patients who had a mismatch. And then as far as the disease was concerned, again, these are the most common diagnoses that patients get transplanted for, fairly similar. The main difference was St. Jude is a cancer hospital. Most of our patients get transplanted for a malignant disorder. And so we had about 11% or 14% non-malignant diseases, whereas at MSKCC, they do about 23% of non-malignant disease transplants. And then we use reduced intensity, lower intensity conditioning regimens. And so you can see over here, about 28% received a reduced intensity regimen, whereas at MSKCC, they use high intensity transplants. And so majority of their patients got, 88% got the myeloablative high intensity, only 3% got the low intensity transplants. But once again, what you will see later on, I think all these differences made this validation cohort that much more important, because what we'll show in the next couple of slides, despite all these differences between the kind of patients and the kind of donors and the kind of diseases and transplants that the two institutions did, our algorithm behaved very similarly in both the cohorts. And so we had near similar prediction capability despite all these changes, which speaks to the validity and the robustness of this algorithm that we developed. And so how did we prepare this data set? So like I said, we first looked at all the baseline variables. So baseline variables could have been categorical or numeric, such as their sex, race, disease diagnosis, donor matching, age at the time of diagnosis, etc. These were available at the time of transplant, and these are usually the variables that have been used in other prediction algorithms previously. So we took those. If they were categorical, we did one hot encoding and the reference level was excluded. And if they were numeric, we scaled them such that the mean was 0 and the standard deviation was 1, so that we could account for the large variability in some of the variables that we have. Some can have a range of 0 to 100, some can have a range of 0 to 10. And so we didn't want to, we wanted to account for that. And so that's why we scaled all of them such that every variable had the mean of 0 and standard deviation of 1. Then we took the longitudinal variables such as the vital sign data, any laboratory test result that they had, serum chemistries, blood counts, etc., number of days that they stayed in the hospital, and did similar scaling with a mean of 0 and standard deviation of 1 for them as well, and then calculated the 6 summary statistics for all of them. And so by doing this, we got a set of variables, and if there were two variables that were highly correlated with each other, with a correlation index of greater than 0.75, we only kept one of them, so that we wouldn't have variables that go one with another, they all cluster together. So out of these total of 261 variables, we kept 35 baseline variables, and 226 longitudinal variables were fed into the model. And so this is how the model development worked. Here is a patient, and this is their timeline. So there is some time, 30 days, that they spend before undergoing transplant, and 30 days that they that are after they underwent transplant. And then there is day 0. So on day 0, we collected the baseline characteristics that I just showed you. And then we looked at all the longitudinal variables that happen -30 to +30. And we put bookmarks on each end. We created summary statistics for all of them, and this was our input data. Now, as you can imagine, there was some missingness in this data because these data were collected over the last 20 years, and they were collected for clinical care, not for research purposes. So not all that data was complete. And so we did data imputation 10 times separately and created multiple different data sets, and used these data sets after randomly splitting them into 70% training and 30% validation cohort. By doing this, we then applied logistic regression and calculated univariate p-values, and all those variables which were highly ranked in the p-values were used for model construction using Naïve-Bayes. And by training and validating this model, we created survival probability. So based on this model, we predicted who's going to be dead or alive, and then actually looked at patients who were dead or alive at that time, and we created these models to see how well did our model perform. And so we use Naïve-Bayes because it's a probabilistic classifier with strong independence assumptions between the features. As you probably know, it's a supervised classification technique used to classify subjects by assigning class labels based on conditional probability. And so for this purpose, each model contained the top 50 variables that were the most predictive in the logistic regression based on their p-values. We then assessed the performance of this model using a number of different methods. We looked at the ROC curves corresponding to the AUC value, which is basically plotting sensitivity against the specificity of prediction. We did a precision recall curve and plotted that. We did a survival probability, which I'll talk about in a little bit using Kaplan-Meier curves. We created a confusion matrix and then also looked at the SHAP values, which are the additive explanations, which give you the relative prediction ability of each one of these variables. So I'm going to show you these three things in the next couple of slides, the ROC curves, the survival probability, and the SHAP values, to sort of highlight what we observed in our study. I am going to show these models color-coded by each other. So for every time point, we created a base model, which only had the baseline variables, which would be analogous to the other models which are currently available and used in the community, and that is shown in gray color. Then we created a longitudinal only model where we only looked at the variables, the longitudinal variables, and did not look at the baseline variables, just the longitudinal variables. And that'll be shown in blue. And then the full model where we combined together the baseline and the longitudinal variables and took the top 50 predictors, and that'll be shown in a yellow color. And so when we tried to do the prediction at 100 days, our longitudinal model and the full model significantly outperformed the base model. And as you can see over here in the ROC curve, the gray line shows the base only model, and the longitudinal and the full models are shown in the yellow and the blue lines over here. And you can see that there is a considerably increased area under the curve. Again, when you see over here in the Kaplan-Meier curves, those patients who are predicted to be dead or alive, even the base model, there is quite impressive stratification, but that stratification improves tremendously when you include longitudinal variables. And then the stratification is pretty impressive when you look at the full model as shown by the p-values over here. So at 100 days, only the transplant year was the baseline variable which showed up in the top 50. So here is a plot of the SHAP values. The SHAP values on the top are the highly predictive, and those on the bottom are least predictive. And those which are shown in red color are the baseline variables. So as you can see, most of the baseline variables for 100-day prediction sort of clustered at the bottom over here. Only one, which year the patient received a transplant, and sort of showed in the top 50. And then the variables which are shown in blue color over here are the variables which were collected before transplant, and those shown in black are the ones which are collected after transplant in the plus 30-day period. And you can see that almost all the most significant variables were collected after transplant over here. Looking at 1-year prediction, once again, we saw that our full model shown in yellow significantly outperformed the longitudinal and the base models. Here are the AUCs shown over here. And then once again, looking at the Kaplan-Meier curves, while there is some stratification at 1 year using the base model only, the longitudinal and the full models are extremely impressive at showing very significant p-values for stratification. And then once again, while a few more baseline variables are shown in red, they creep up in the SHAP values. The most important variables are still the ones which are in blue and black, such that they are collected before and after the patient undergoes transplantation. And then when we looked at the 2-year prediction, the full model still significantly outperforms the longitudinal and the base models. Once again, the Kaplan-Meier curves over here, we see impressive stratification in the full model with very highly significant p-values. And once again here, at 2 years prediction, some of our baseline variables shown in red are creeping up much higher, but still majority of the variables over here are the longitudinal variables which are collected before and after transplantation. So this is a summary of all the ROC AUC values. You can see at 100 days, 1 year, and 2 year, the golden and the blue, which is the full model and the longitudinal model, they significantly outperform the baseline model shown in gray. What you do observe over here, though, is as you go from 100-day to 1 year to 2 year, the differences between the prediction ability sort of go down. And so what does that mean? If you remember, I told you that we only looked at data from day minus 30 to day plus 30. And then we are trying to make a prediction at day 100, 1 year, and 2 year. And so if we only look at data up to 30 days after transplant and make a more distant prediction at 1 year or 2 year, we lose some of that predictive ability, because a lot of things happen and change between day plus 30 and 1 year or 2 year. But we are fairly accurate at making a prediction based on data collected up to day 30 for day 100. So that's why there is an impressive predictive ability over here at day 100, which is very different from the baseline variables, but that predictive ability decreases. What our hypothesis is that if we could collect more data, let's say if we collected data up till 6 months, then once again, our predictive ability for 1 year and 2 year outcomes will be significantly outperformed, similar to what we are doing over here. This is again a summary of all the SHAP values, and I've shown you the same figures in the previous slide, but I wanted to put them all together. So once again, what you see is the baseline variables are shown in red over here, and you can see that at 100-day, all those baseline variables are clustered at the very bottom. At 1 year, some of these variables start coming up, and at 2 years, they are high up. And so what does that mean is that while the longitudinal variables collected before and after transplant still remain highly predictive of outcomes of mortality at these time points, the baseline variables, just because they have such an impressive impact and because we are not collecting longitudinal variables beyond day 30, some of these baseline variables creep up in the predictive algorithm at 2 years. And so once again, I think if we collect longer longitudinal data, we will see that the longitudinal variables continue to remain highly predictive even at the distant time points. And so once again, I'm showing you the summary of the Kaplan-Meier curves. This is for 100 days, 1 year, and 2 years. And on the top is the base model, in the middle is the longitudinal model, and at the bottom is the full model. And in all these situations, the full model significantly outperforms the predictive ability at all these time points. So we drew some conclusions from these model assessments, and some of those I've already talked about as I was referring to all these things. The ROC curve AUC values were consistently higher for the models incorporating the longitudinal variables, the full model and the longitudinal only model over here. And the improvement in prediction of overall survival with the inclusion of longitudinal information does tend to decrease over time, but I think that's probably because of the short window of observation that we have. But despite that, the discriminatory power of the model at identifying the patients who are predicted to be deceased or alive using Kaplan-Meier prediction, it remains highly impressive at stratification, even at later time points in these patients. And we think that the decrease in the discriminatory power of the models incorporating the longitudinal variables at later time points is likely due to the relatively short window of observation for the longitudinal variables, which was, as I said, only limited to 30 days before and after. So by extending the window of observations, we hope that we will be able to further improve the prediction ability at distant time points for these patients. Of course, our model had some limitations. So as you can imagine, the model is only as good as the data it is based on. And we did have a lot of missing data that we had to impute for. Because this was a retrospective analysis, the data was collected only for clinical purposes. Unfortunately, we could not make sure that the data, every time point, every data was collected. And so that does remain an issue with this model. But despite that, we actually had fairly good prediction. And then this model was created from the data from a single academic quaternary-care referral center. Our patient population may differ from other centers. Our patient population may differ from another hospital within the same city or other cities. And so we did try to do external validation from another transplant center in New York, but that center also happens to be a similar center to ours with a similar patient population in many ways. And so the generalizability of this model remains limited. We are currently working on further validating this in other centers. So hopefully we will be able to make sure that the model performs appropriately at other centers as well. And then this is a general explanation or general limitation of all machine learning models. If there are any biases in treatment, such as racial, ethnic, or economic biases, the model will learn those things, and we wouldn't be able to tell what those biases are and that the model will then predict based on those biases built in. And so I think this is something that we have to be extremely cognizant of when using machine learning model, especially for prediction of outcomes in healthcare. And then in this particular study, we only looked at the binary endpoint of mortality, whether a patient was dead or alive. Um, we did not factor in the time to death. We did not factor in other variables that led to patient's death. And as you can imagine, it would be much more helpful to predict what led to patient's death so that we can do something about that. So that's one limitation of this study. And then again, this is a general limitation of machine learning models. When we throw in 200, 300 different variables into a model and the model picks some things, we don't always understand why those variables got into the model. Of course, there is some biological explanation behind it, which we don't completely know or understand right now. It would be great if we did, but that's one of the limitations of such artificial intelligence and machine learning models right now, that we don't completely understand what is happening in the back end. And so we have some ideas for what do we want to do next. First of all, we want to incorporate a time to event analysis because that would be extremely helpful. Right now, we looked at a binary endpoint at 100 days, 1 year, and 2 years. So whether a patient was dead or alive at 100 days, 1 year, 2 years, we would like to understand and predict the time to event outcome. For example, if the model could tell us that this patient has a high risk of death within the next 90 days or next 180 days, I think that will add a lot of robustness to this sort of analytical pipeline. We also want to model post-transplant complications such as graft versus host disease, infections, relapse, ICU admission, etc. And if we can reliably predict these outcomes, now we are playing because now we can do something about these. If I know a patient is going to develop an infection in the next 7 days, I will try and find out why they are susceptible for infection and I will do something about it. I will try to prevent that infection from happening because that infection could lead to the patient's death. And so knowing what led to patient's death will be extremely helpful, or predicting rather what led to patient's death would be extremely helpful so that we can do something about it. And so we also want to go from this model to a predictive solution. I always tell my clinical colleagues that a machine learning model is like a paper map. You have to know how to use that map to go from location A to location B. But a predictive solution would be like Apple Maps or Google Maps. You put in what location you want to go to, and the map tells you, okay, turn right now, or take a left turn at the next traffic light. And so what we are hoping to do is to take this model and integrate that within our electronic medical record, which at St. Jude is Epic. And by integrating this model within Epic, what it would help do is the model will keep running in the background. And when a clinician is in a patient's chart and looking at that, and the model with a certain degree of reliability predicts that this patient has a high risk of developing an adverse event, the model can give a alert to the clinician that, hey, this patient has a high risk of developing an infection in the next 7 days. Please do something about it. And that alert will be very similar to what Google Maps or Apple Maps tells you when you're driving your car, turn left now. And so that this model can become into a predictive solution that actually helps clinicians do their job better. And so I'd like to conclude this by saying that, we all think of machine learning and artificial intelligence as this sort of a crystal ball that, it'll just tell us what's happening. But I don't think it's a crystal ball. I think it's more like a co-pilot. It runs in the background with you and it supports you in doing your job better. And so it still needs a lot of human input. Medicine is hard, it's complex, and the more help we can get, the better it is. And so we want to develop this machine learning model and a predictive solution as a co-pilot that helps clinicians make better decisions for their patients. The decisions are still going to be made by the clinicians themselves, but at least there will be some sort of an additional support for the clinicians. And so I'll conclude that by saying that we can use longitudinal data, which is extracted from the electronic medical record, to train a machine learning model and make accurate outcome predictions. And in this proof of concept study, we highlighted the importance of incorporating the longitudinal data, which is collected after transplantation. And we hope that this model may serve as a clinical decision support tool and supplement provider judgment and the gut feeling that clinicians have to improve clinician experience as well as patient outcomes. And of course, internal and external validation of these models will allow for more widespread application with a number of different endpoints. And so if you want to read more about this article was published recently in Blood Advances. Yewang Zhao, one of my biostatisticians, was the first author, and this is the paper. You can go to Blood Advances website and download it. There's a huge supplement that we uploaded with that, and we are happy to share the source code if anybody would like to replicate this at your respective centers. We are more than happy to work with you and help you develop this further. So with that, I'll thank my entire biostats team who helped me develop this model, and thank you all for your attention. And I'll be happy to take any questions now.
Thank you very much, Dr. Sharma. Very interesting talk. And I think I would say that I think I have got the best kind of explanations. Like I never have thought that the way you explained it is like very understandable as a computer scientist. So you are really thorough in that part, and I appreciate that you have that knowledge in terms of explaining your work. It's really good. Yeah. So we do have a school of data science here, and we are really interested to kind of collaborate with you if you need to move forward in the machine learning area, and we will really connect with you in that sense, like even after the workshop. So
Yes, of course.
yeah, so I know when I was with Dr. Choi, I think I was in University of Michigan, and I was a postdoc fellow and working in her lab, and we did a review paper on like machine learning techniques on the transplant patients, and we found that around in like 5 to 6 years before 2015, 2020, there are just like a handful of works, like just 27 papers we found, in which really the challenge was the data set. As I have seen that in 10 years, we have a very small patient cohort, and this disease is very complex. So it's not that easy to just apply something without understanding the thoroughness of transplant, right? Yeah. So
No, that's absolutely true. And that's why I think collaboration is the key over here, because as you saw, we had about 700, 800 patients at our institution, which,
yeah,
I mean, for a single institution is a fairly large number, but that's not enough to reliably make a machine learning algorithm, especially if you're using 200, 300 different variables to start making
yeah,
that prediction. And as you rightly said, this is a very complicated situation. So you do need to use those large number of variables, otherwise you lose a lot of this predictive ability.
that's true. That's true. Yeah. So I have a couple of questions, Dr. Sharma. So the first one is when you have developed your model internally and validated it, what were the criteria in like matching those patients with the external data that you have from MSKCC? Like, yeah.
We actually didn't do any matching. So we took everything that we got and we applied the model as it is. And then
Okay.
we looked at the same variables that I showed for our data within our training and the validation cohort. We applied the same exact characteristics to evaluate if the AUCs and the ROC curves, they were similarly discriminative in the validation cohort. And we found that that was the case. I didn't know how much time I would have, so that's why I kept it short and I just showed you within our training and validation cohort, but we got exactly the same results with the validation, external validation cohort also. And in our paper, we have described all of that.
Okay. Okay. Thank you. And just a quick question, you have mentioned that you have done the correlation analysis, and the correlation index was 75%. So is that a criteria that you use for the literature for keeping 75%? Yeah.
Yeah, so if there were two variables that had a correlation of more than 75%, then we excluded one of them. So I'll give you an example. White blood cell count, that's a very common blood test that we do. And neutrophils are a type of white blood cell. And so when your neutrophil count goes up, your white blood cell count also goes up. And so they generally move in a one-to-one pattern. Now, of course, there are other blood cell types as well. So it's not exactly one-to-one, but it is very similar. And so neutrophil count and white blood cell count will have a correlation index of greater than 75%. And so in those situations, we only kept one of them and not both. Otherwise, if one was significant, the other would also have become significant. And our top 50 variables would have just been limited by these similar looking variables. So that's why to keep only one of the important ones, we just kept one if there were two variables which had a correlation index more than 75%.
Wonderful. Okay. So we can take the questions from the audience. You can unmute yourself and ask question from Dr. Sharma. Okay.
Hi, Dr. Sharma. I'm Shumed. I'm one of the faculty at SACS. First of all, this is a very clear presentation. I enjoyed it thoroughly. I was at your similar position in Canada. I was an assistant scientist there. I did almost similar stuff like you. So I have no question regarding your analysis. It was very clear, but I have question regarding the future step. Like, is this data available for other people, or is it an open source data? Or if, let's say, I want to work with this data, what's the procedure to get this?
Yeah, so the clinical data set is, within our St. Jude, and because it's a patient data set, there is a lot of identifiable variables involved in this. It's not open source because we can't just share it, but we are welcome to having more collaborators with us and work within our environment. The source code for the model, though, is available, and we are happy to share that with anybody who would like to get it. I don't have the GitHub code in front of me, otherwise I should have shared that.
Sure. I'll email you later to discuss more about it. And that brings the next question. So for future collaboration, is there a way of doing a data sharing agreement with Mehari and your institute like that? Or is it still just focused on your institute only and not shareable at all?
You know, personally, I feel we should just be able to share the data. Um, I can tell you that our legal teams have much more control over what we can and cannot share as far as patient data is concerned. And so if you'll email me, I'll definitely get in touch with our legal team and see what sort of collaborative agreement we can have and move that forward. I don't want to misspeak and say that, yeah, absolutely, I'll share all the data with you. And then the legal team
Makes
back
sense.
and
Makes
says,
sense. I understand.
no, sorry, you can't. And so there are some regulatory requirements that we need to just jump through, and I can consult with our hospital's legal team and figure that out.
Sure. Thank you so much. We'll talk more.
Yep. Okay.
So Dr. Sharma, one question from our student, Nistaku. What ethical challenges arise from relying on AI for medical prediction outcomes and treatment recommendations? And how can we mitigate potential risks to patient autonomy and doctor-patient relationship?
Yeah, no, that's a great question. And I sort of briefly talked about that. So, I'm not saying this happened in our data set, but it has been shown to happen in some other data sets. And I'll give you an example of that. And so, African American patients, there has been sort of a bias against them in healthcare. Several studies have shown that African Americans patients, they tend to get fewer treatment options from their clinicians. They often don't get some of the more expensive treatments compared to their white counterpart patients. And so, and there are many reasons for that without going into too much detail. But what it does is when you create an unbiased machine learning algorithm, such as what we created, if African Americans were systematically getting less treatment, just to make that very obvious, if they were systematically getting less treatment because of something else that was going on, the machine learning algorithm will think or will assume that African Americans should just get less treatment. And so any biases that happen because of racial, economic, or other social issues get exacerbated in such machine learning algorithms. And so I think the first thing that we have to do is to be cognizant of that sort of a thing happens, and then try to mitigate those while we are developing these models in whichever way we can. I don't have a very good way of telling you how to do that, but at least knowing that happens when we create these models is important. The other thing is, these models, when we create them, they should not be autonomous. And so that's why I said that we develop these models such that they are a co-pilot to you. You still need a clinician to understand what's going on with the patient, to try and have that conversation with the patient and make a decision together. So this model is to help the clinician make a better decision together with the patient, not to replace the clinician. And I think that's where your second part of the question about autonomy and doctor-patient relationship comes in. And so we should be cognizant of how we use these models in our clinical practice.
Thank you very much, Dr. Sharma. Just a last question from my side is like, as a clinician, you have started using some of the machine learning techniques. What do you think, what are the pros and cons of using AI in the clinic side? Yeah.
No, that's a great question. So, as I sort of showed in my initial example, there are expert clinicians who have been practicing medicine for 40 years or so. They have accumulated so much experience that they don't need any external help. They know, it's sort of like a gut feeling. They see the patient and they know. And so that's the experience that matters. So that's number one. And so I think these machine learning algorithms can be extremely helpful for younger clinicians who don't have as much experience yet, so that they sort of give them a little bit extra help. I think of it like training wheels. Of course, the clinicians are trained and they know what to do, but if they can have these guardrails so that they don't miss something, that's helpful. The other thing is, in today's world, where everybody is very busy, and you have like just 15 minutes to see a patient, you may not be able to see everything about them. And so you don't want to miss something. And that's where I think some of these algorithms come into play, where they can highlight, for example, the algorithm can say, hey, your patient is going to be at a high risk of developing an infection in the next 7 days because they have this, this, and this. Now, if I just had 15 minutes and there was a possibility that I could have missed those things, then the patient would have been at risk. But if the algorithm specifically tells me that, hey, look at this, this, and this, and these are the things that put this patient at a high risk of infection, I'm going to pay attention to that. And so then once again, it helps with clinician fatigue, attention span, the time constraints that we have. So I think all those things together can be abrogated by using artificial intelligence.
Wonderful, wonderful. So it gives me a really good perspective from the clinician side, basically. And it's very hard for us to find kind of a good collaborator, like even like finding a clinician for our projects, because we just kind of very hard to find like collaboration as we have from Dr. Choi. But definitely it will be a really good start for us, and we will connect with you for the future collaborations. Thank you very much.
Okay, sounds good. Thank you.